From Diamond Pharmacy Services, this is PodcastRx, a monthly show that takes you behind the counter of the nation's largest correctional pharmacy provider. We bring you conversations with pharmacists, nurses, managers, and other Diamond staff about the topics and issues we see in corrections, long-term care, and community health settings. Our chats aren't limited to purely pharmacy topics, and they aren't strictly clinical either. So if you're a healthcare provider or just enjoy healthcare podcasts, we think you'll enjoy this show. On this episode, Henry So of the Optics clinical team stops by to address questions related to transgender patient care. We discuss the steps pharmacists can take to optimize care for transgender patients, take a closer look at available hormone therapies, and talk about clinical questions that Henry and his Optics colleagues receive from providers. I'm Adam Campbell, and this is PodcastRx. Well, it's always a pleasure to welcome pharmacist Henry So from the Optics team back to PodcastRx. And this time, he's actually live and in person with us in our new podcast studio space, no less. Henry, it's so good to actually see you. How are you today? And what brings you to headquarters?
I'm doing really well. Thanks for having me again. What brings me to headquarters? It's Halloween, and we're trying to do some costume competitions. So you guys better watch out. Yeah. Pharmacists are coming for you.
I'm sure the pharmacists always bring their A game when it comes to Halloween. Those who are unfamiliar listening to the show, Diamond always does a really great Halloween celebration with employees, little friendly costume contest between departments, and the pharmacists are one of the perennial contenders for sure. There's a lot of them, and they coordinate very well. So anxious to see what you all look like today. And also, Henry does not work here in Indiana, PA. He lives across the state, Mechanicsburg, right?
Yeah, Mechanicsburg, right next to the Capitol.
Yeah, so he has to drive a ways when he does come out here to see us, but we're really grateful you took the time to be on PodcastRx, so thanks again, Henry.
Yeah.
So I wanted to have you on because you recently gave a webinar addressing a very important topic in corrections healthcare and healthcare in general, that being care for transgender patients. And you and your Optics colleagues field many questions per month on this topic, particularly about hormone therapies. And so given the frequency of questions from providers and the increased attention overall on transgender individuals in jails and prisons, it's no doubt going to stay a top-of-mind topic for you and your colleagues. So with that, I wanted to have you on just to get a pharmacist's perspective on some questions about transgender care.
Yeah, this is awesome. Thanks for having me. Love contributing to the podcast scene, especially if it's for patient care.
Absolutely, and you're one of our go-tos now, so get used to that. So just to get a little context, Henry, transgender people in the incarcerated population, I understand there's a bit higher of an incidence.
Yeah.
In that. Can you tell me more about that?
Yeah, I think great way to put this for at least transgender in terms of identifying the epidemiology of it. It might be one of those things where you might actually be able to say maybe the numbers are lying, and I'll elaborate about that a little bit. The statistic that I'm aware of in the U.S. population is at least 0.5% of the general population are transgender, or at least express that they are, they identify as such. And technically, from what we've seen based upon some clinical trials and other epidemiological studies for correctional medicine, so just to put it up front, to put the perspective in, we might see at most about 6% of the U.S. general population be incarcerated, whereas for transgender individuals, a staggering 21% of those individuals will be incarcerated within their lifetime. So that alone, just being able to see, a lot of different people get incarcerated, but 21% of the time trans patients in the U.S. it's pretty alarming.
Yeah. And this is something, I'm pulling this directly from your presentation. I kind of reiterate, you cited a statistic, that quote, and I'll link to this study in the show notes. It has been observed in large populations of transgender individuals that 30% postpone care due to prior disrespect or discrimination, 10% postpone primary care outright, and that, quote, overall 28% delay care and 19% have denied care outright. So an outright postponement and denial of care will, of course, leave transgender patients vulnerable to all manner of health issues on top of already unique health needs. And then I imagine this only can get worse in correctional settings.
Yeah, it definitely could get a little bit worse. It's not something that I'm too privy to in terms of the correctional setting. And this is kind of why I alluded to things being slightly underestimated in terms of the epidemiology. There are many people who withhold information from their healthcare providers, family, friends, etc. That can be fairly benign or fairly serious. But something like coming out as trans can not only impact your relationships, but it could possibly impact how you're perceived, treated, and unfortunately maybe affect your care. So in corrections, I would say it does begin to be a bit more challenging. Not only are you in a bit of an isolated healthcare setting with not many resources available, you're grappling with a new field of medicine involved with hormonal therapies that apply its use in the opposite gender. So just saying all those different things and terminologies and jarring terms can be kind of difficult for a provider to grapple with this kind of condition or medical field. And then couple that with someone who is incarcerated, who's trying to get the high level of care that they maybe never did out in the community. Just trying to see that go down in correctional settings can be a little bit difficult, a little bit muddy in my opinion. So it could get a little worse.
Well, I wanted to ask you, a pharmacist like yourself, how could pharmacists that are in your position, help into overall improving that situation for transgender patients? So what kind of steps to start can pharmacists take in directing care of trans patients?
Yeah, there's a lot of different things that we could use, a lot of different hats that we have as pharmacists that advocate for patient care, that reinforce learning, that reinforces teach-back methods. But this one's a little bit different in the sense that pharmacists usually are a little bit boxed out in a little bit more of the hands-on care that we normally see in nursing or different providers, mid-levels, etc. But I think the interesting thing about pharmacists are we do have an uncanny ability to tap into resources, interpret it, make it nice and pretty so that everybody can see it. I think one of the big things that we can use as a pharmacist for this specific field of medicine is just awareness. Mm-hmm. Any department that comes up from really nothing, there's rules that you need to establish. You need to make sure that people come in at a certain time. I don't know, greet each other a certain way. And that translates to a couple different guidelines that I've looked at personally that encourages some pharmacists, some healthcare providers to actually start from scratch and build a clinic that's welcoming from the ground up. So that could be bathrooms that are labeled with, he, him, they, she, whatever it may be. Not really specific. But yeah, I think aside from being a nitty-gritty pharmacist, building those things, I think the awareness and the education is really important. Just understanding terminologies, definitions, identities, and different ways to approach a transgender patient and trying to disseminate that to a provider who may need that.
Yeah.
Yeah.
And what are ways that you're especially involved in the education and awareness part of this? What are ways that you could inspire the confidence in your providers with trans care? Yeah,
I think that's a really tough one, inspiring confidence, because these are one of the things that we have the information in front of us. It's there. You can definitely rehearse this whole thing, whether it is real or not, as in, hello, X, they would like to be placed in that room, or, different ways that you can mechanically go through with this. And the confidence part is, that part comes with the fact that, a level of seriousness needs to be taken with it. And I'm sure everyone does. It's just a matter of, like, I've dealt with in the past with providers who discuss these things and it just doesn't feel like it's taken as seriously until I've met a recent provider who actually really put into words why I personally care about transgender medicine and why we need to have confidence and how to build that confidence. Treating these patients, and I think the story that how it basically went, it was out in Texas, treating these patients for the first time and hearing their pain and trying to understand their pain and place themselves in that position where they constantly have to teach or guide other people to treat them correctly. It's a very painful process, and it makes people lose, I guess, trust in the healthcare setting. So basically what I would say is I would just challenge everyone to just read the things that you're supposed to read. Read the UCSF guidelines, the WPATH guidelines. Read it and soak it in. But once you finally have all these training materials in your mind, go and treat one of these patients and talk with them just like any other person, and just try to, place yourself in their shoes. That might be one of the bigger things that we need to approach with, because the information's all there is basically what I'm trying to say.
Yeah. Getting into your day-to-day work, of course, we know optics pharmacists don't get to be directly one-on-one with patients.
Yeah.
But what ways have you been, when you've been fielding these questions about whether it's about safe transitioning, hormone therapies, or how have you been living out what you were just speaking to?
Yeah, I think that is a very good question, because there's more questions that immediately come into play as soon as we treat our first patient with, hormonal therapies. The first question that I ask them, or at least ask, in conjunction with other providers, teams, where are we going? What's the goal? Is it male to female? Is it female to male? And then there's a range. And, if you look at the different literature that we try to put out or recommend someone to read through, there's different goals other than just male to female or female to male. There's a different spectrum, or a fairly large range of sexual characteristics that some of these individuals want to capture, not capture. They want to retain their own physiological hormone levels, but after they were able to capture certain, sexual characteristics like breast development. So I think the first thing that we need to ask ourselves as pharmacists is, what is the goal? What are we trying to obtain? Are we trying to get breast development? Are we trying to get some redistribution of fat? Are we trying to get rid of some masculine hair? And all of these goals align with certain pharmacotherapies. And if we know what the goal is, if we know what the timeline is and the onset of those goals that appear, those are some of the things that we push and direct our physicians in terms of treating, in terms of like a very tangible outcome-based therapy. Yeah.
Well, because so many of the care questions that you receive from partners here, Diamond, involve hormone therapies, I thought it'd be useful to get a sort of one-on-one breakdown of the common therapies, masculinizing and feminizing, and what common clinical issues are associated with them.
Yeah.
Kind of a bird's eye view, but still definitely would be useful to our partners. So I wanted to ask, for feminizing therapies, what are the major types that are available?
Yeah, so for feminizing therapies, we currently have some oral estrogens, we have transdermal estrogens, injectable estrogens. Then we have things such as like progestogens. And I'll definitely get into that. But basically, for feminizing therapies, what we all need to understand is that essentially there's a goal estrogen level that we're pursuing. Within that goal estrogen level, and I could, I can't say that I know that this goal estrogen or this goal physiological hormone level is off the top of my head, but the number is pretty solid. It's consistent. It's there. But essentially, the first thing that I want to say as I rattle off, estradiol, valerate, cypionate, whatever it may be, injectable versus transdermal, really the thing is that I really drive home in terms of our providers who ask us for these consultations is that regardless of what level that they're sitting at, as long as it is within, a female physiologic range, be patient. There is no one specific estrogen level that corresponds or creates or develops certain sexual characteristics that one female would have over the other. So, for example, my take on this whole thing after perusing a lot of different stuff is you could have a female that has excessively high normal estrogen levels, but not have the physical sex characteristics that you would expect to have in a female of a lot of estrogen, whereas a female with very little estrogen could have sexual characteristics that far exceed what we would expect a normal estrogen level should be, or a high one, or it should be at a high estrogen level. So just extrapolating that basically is what I'm saying is as long as they're on estrogen and they're getting towards that physiologic range, really the body works in however way it wants. If it develops what it needs, then it develops what it needs. There isn't a level that corresponds with that. Yeah. So then we have progestogens. Progestogens are, I would say it's a very flippant agent. Not a lot of, it's either yes or no.
Okay.
It either works or it doesn't. The literature out there is very flippant, as in it's very anecdotal. Some people say it works, some people say it doesn't, some people say it improves mood over estrogen. But overall, the evidence really isn't there for progestogens. The only real statement or clinical pearl is for those that it works for, it works. For those that it doesn't, it doesn't. And clearly why it's not a first-line therapy or why we usually recommend it is because it can have anti-androgenic effects as well, which can produce male sex characteristics or certain things like hair in certain unwanted areas.
Okay.
And last one is androgen blocking therapies like spironolactone and 5-alpha reductase inhibitors. Yeah.
Yeah.
Do you have any questions about that?
Could you go into those two a little bit?
Yeah. So for at least androgen blocking therapy, spironolactone, 5-alpha reductase inhibitors, for a lot of our providers out there and other ancillary nursing healthcare staff, spironolactone probably raises some eyebrows because we typically see that in heart failure or any kind of blood pressure management. And what we typically use it for is for kind of like a diuretic effect. It spares potassium because most of these patients are on other diuretics that could pull out potassium, and potassium has a fairly vital role in the cardiac action potential. So could definitely see some issues with that, and linking that point with spironolactone, seeing it used, definitely expect some elevations in serum creatinine, potassium. But yeah, we use it because it has a fairly full and robust anti-androgenic effect. And what that does is it just blocks testosterone. And the bottom line is, or the bottom dollar is, no matter however optimized your spironolactone therapy is, could confer lesser usage of estrogen therapies to decrease costs overall. Basically, what we see with spironolactone therapies and with the lesser extent 5-alpha reductase inhibitors like finasteride, dutasteride, we see breast development typically. Breast development, anti-masculinizing therapies, and loss of hair in certain areas. And really 5-alpha reductase inhibitors, they are second line in a way. They're not as they don't fully block androgen receptors. Fairly benign though, whereas your spironolactone fully antagonizes that, but causes a lot more side effects like low blood pressure, hyperkalemia, acute kidney injuries. But it has been seen in women who have used this for hair loss therapies. Doses of up to 200 to 300 milligrams per day were seen to be used and safe and efficacious.
And of those feminizing therapies, what's considered to be the first line?
I would definitely say the first line therapy would have to be your estrogens. That's what's going to produce a physiological, similar individual. But yeah, the estrogen therapy is pretty much first. You want to get them right in that range. And then the anti-androgen therapy comes in second to play. And I'll tell you guys why. But the anti-androgen therapy comes in second to play to finally get that testosterone level to below a certain goal. But yeah, so basically why we introduce estrogen therapies first is because we actually are extrapolating that idea from younger females who have later onset puberty who are taking estrogen therapies as well as anti-androgen therapies. What they saw was if they introduced the anti-androgen therapy a little too close to the initiation of the estrogen, they saw some premature breast budding and fusion where the breast development wasn't as extensive as if they first pursued a physiologic estrogen first and then pursued a testosterone level less than, I believe it's less than 55 or 60 nanograms per ml. Don't quote me on that though.
Okay.
But it's still a less than type of goal.
Okay.
Yeah.
Would you say then that most of your questions then that are coming in for the feminizing therapies are primarily then about the estrogen?
Yeah, primarily about the estrogen, switching between the two. We, not only as clinical pharmacists do we keep up to date with what's going on in terms of literature, We have to keep our vision really up for shortages, any kind of back orders. And right now we are experiencing a back order of a certain formulation of estrogen. So being able to pivot and recommend something that's just as efficacious and safe with equivalent dosing or equivalent levels that need to be observed or monitored. Yeah, so that's something that we've been encountering a lot more transition. How do we convert one formulation to another? And I am here to say that we have looked into it a couple times. There's some review articles out there that look at how to extrapolate certain doses to certain serum levels. We looked into it a little bit. There is some mention, but basically what I agree upon, a couple other teammates agree upon, is that when you have to transition, keep the dose around the same, or maybe start it back at the initial dosing, which is listed per guidelines. And then the first and foremost thing is you're going to want to monitor more round the clock, or not round the clock, monitor more judiciously to see if once that switch occurs that you can keep them within that range. Because really, like I said, and I think this is the first time I'm saying it actually, there isn't one estrogen formulation that is superior to another in terms of efficacy or safety. Safety, maybe I'll touch upon that a little bit more. Transdermal formulations are a little bit more tolerable. But yeah, overall, there isn't one formulation that is superior to the other. As long as you can get that physiologic estrogen level to where it needs to be, that's where the efficacy shines. That consistent delivery and consistent serum concentration that we want.
And what about switching over to the masculinizing therapies? What do we have available there?
Yeah, masculinizing therapies. Obviously, we have testosterone, pretty commonly injectable. We do have some gels and creams and oral formulations as well. And I think I should go back to this really quick.
Sure.
I do want to say this for the estrogen therapies, as I'm discussing all the different formulations for testosterone. I want to say this for everyone out there who's utilizing estrogen products. Steer clear of things like conjugated equine estrogens. Steer clear of oral estrogens. Steer clear of compounded estrogens. There isn't really a real reliable way for at least the conjugated equine estrogens and the compounded estrogens. There isn't a reliable way to get accurate serum blood draws on that. So if you are utilizing a product like that, it can be a little inconsistent in terms of absorption and how it distributes in the body. But linking it back to testosterone.
Okay.
Same thing. Avoid those compounded products. Usually it's actually preferable to avoid oral products due to the liver toxicities involved. Okay. That's pretty much what we have for our masculinizing therapies. Just testosterone either as an injection, either as a patch, or something that you rub on your upper right deltoid or something like that.
Right. And you don't have to, as with the feminizing therapies, as you explained, you don't have to have the different types. You don't have to have another type of therapy to come in and negate the effects of the testosterone or improve, or am I understanding that correctly?
I think
you had to use some in conjunction.
So yeah,
it's primarily just testosterone.
Yes, primarily testosterone in female to male transition. It's the female or male to females that transition that also need an additional anti-androgen blocking agent. Right. Because I didn't go into it. If you didn't get an orchiectomy or the removal of the testicles, you're still going to produce testosterone.
Sure.
So might as well do something that blocks it. That's why your male to females have that. But your female to male, they really only exclusively rely on your testosterone therapies.
Okay.
Yeah.
I did want to go into some questions surrounding just the therapies in general. I think you spoke to this a little earlier, but I'll ask you again. How important is it to understand the timeline of developing secondary sex characteristics when prescribing hormone therapies?
Oh, yeah. I should have I should have brought that up more extensively. Yeah, thanks for reminding me. I think the onset or the timeline, there is a nice little table that I put up on one of our most recent lectures for our health partners. But what I would say is, the key for this table is patience is key. Some of these sexual characteristics develop maybe in 2 months, 3 months, or they disappear in 2-3 months.
Yeah.
They could take as long as 2 to 3 years to finally fully develop. And the link between that is I usually talk with providers who are grappling with patients that are a little bit unhappy with the results that they've been obtaining so far. And what they're asking is more aggressive increases in dosing, frequency, etc. And I look at their chart and they're really only, let's say, 1 month into the whole ordeal. And what I would always tell the provider is these things take time. The onset of these characteristics are fairly well detailed. So, don't increase these doses too quickly. Be patient. Explain to the patient to be patient, because as you rapidly increase these doses, I mean, they're hormonal therapies. It's estrogen. It's testosterone. One of the most extensive side effects could be like a clot or some sort of cardiovascular event. So, in order to safely obtain those goals, you have to be patient and understand the timeline.
Yeah. And what are some of the other safety considerations? You did briefly touch on it, but
yeah, that's a big thing. Safety it's a huge thing. So we have deep vein thrombosis, pulmonary embolism. We could have stroke in certain patient population. We could have major adverse cardiovascular events, especially with testosterone therapies. Increases a lot of your hemoglobin in the body, certain amount of red blood cells. Could experience things like migraine. You could experience many different things, even a micro oil embolism with certain products that are formulated with certain oils that, if they are inadvertently injected and end up in the lungs, could be a pretty bad ordeal for them.
Sure.
But yeah, these agents are not benign agents, whether it ranges from something very acute like a cardiovascular event to something chronic, which promotes tumorigenicity or oncogenicity or the growth of tumors and things like that. So definitely have a range of their side effects.
Yeah.
Yeah.
And and of course, as clinical pharmacist, you're in a very unique position to advise on these things because you have that thorough understanding of the pharmacodynamics and.
Yes. Because we advise not only just based upon, because I always say this all the time, treating a disease state like a silo. Of course, we're approached to treat a disease state, or not a disease state in this case, a select field of medicine like transgender medicine. But if it's a 59-year-old female who has hormone receptor positive breast cancer, or it starts to get a little muddy, but if there's other oncologic conditions that these hormones can promote the growth of tumors, we have to take that into consideration and be able to, distance ourselves from transgender medicine and be able to count those contraindications and be able to recommend, hey, maybe not start hormonal therapy yet, things like that. Yeah.
Right. You did speak to this a little earlier, but I wanted to know a little more. How often do you have to advise providers who are converting from one hormone therapy or product to another?
How often?
And is it difficult to, as you were saying, like looking at new formulations?
Yeah.
Is it pretty straightforward, or you often have to do a lot of digging when you do something like that?
That's a good question. How often? It really only came to light when I believe estradiol cypionate went on back order. So we had a lot of providers calling and asking about switching to Valerate. We had that a lot. And in terms of the frequency, really it only arises when cost is seen to be a little too high. There still are some name brand products, name brand patches, and oral formulations that are very, very expensive, and always would encourage providers to take the opportunity to switch to other generic products, because as I've mentioned, there isn't one specific product that has superiority over the other. And yeah, when in terms of the complexity that you ask, I kind of answered it. It really isn't that complex. There really isn't one agent that's better than the other. There are it gets more complex if there's things like, hey, I experience migraines and I get an injection every 2 weeks. What I'll say is let's divide that injection dose by half and dose it every week so that you're getting a lesser dose or a lesser dump of a huger dose more frequently rather than less infrequently. If that doesn't work, then we start, telling them maybe use a transdermal patch. That has been known to alleviate some of those side effects. But yeah, overall, it's pretty easy as long as you're, pursuing a specific estrogen level or range that's safe.
What are some of the other noteworthy clinical considerations that you've had to make in your time with Optics advising on transgender care issues, hormone therapies, all of it?
Yeah, I think that's a really good question. I have to think about that one really quick. I have a pretty good one. I think this case in particular just kind of goes to show why we shouldn't treat transgender medicine as something by itself. There's other things that are going on, other things at play. And it was something as simple as, and I remember the way it was framed was, I have someone on testosterone therapy and they have crazy high blood pressure. And that's common to see in testosterone therapy, elevated hypertension. There's even recommendations to increase monitoring and also initiate an antihypertensive whenever you see those consistent values, that are elevated. And I really think that it's a very simple one, but I only encountered it once because it might have been just maybe the one provider that just took a step back from the patient profile and looked at the blood pressure. But yeah, I think what I've noticed as my most oddball one was just a provider that was absolutely stumped as to what to start the patient on, as in for antihypertensives. And they were on testosterone therapy. And yeah, I pretty much walked them through what was, first line treatment options for them, things that don't interact. And I think I basically had the provider walking away saying, wow, there's a lot of other things at play that I need to monitor and keep track of. Even like monitoring signs and symptoms or teaching the patient about the signs and symptoms of DVT in the leg could go miles, could go the distance for a lot of these people. So understanding the side effects and stuff like that, and the ancillary problems that may arise from hormonal therapy.
Right.
Yeah.
Well, it's a very complex field of medicine, and it's certainly to have a pharmacist on your side to be so close in the consultation process is always going to help take that care to the next level.
Yeah, it's always our pleasure to have an extra pair on eyes for the provider team and the patient as well.
Yeah.
Yeah.
Well, Henry, I really appreciate you stopping by here on Halloween to share these experiences and your expertise again with us. And like I said, you're one of our favorites now, so be prepared to be on more. But it is so good to actually have you here in studio and talk with you in person.
Yeah.
So
the studio's great. Thanks for having me.
Absolutely. Thank you, Henry. This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.